Welcome back to the Deep Dive. Today, we are wrestling with something almost everyone knows firsthand. Headaches and facial pain.
Right, incredibly common.
But the real challenge, and what we're digging into, isn't just recognizing the pain, it's the maze of figuring out why. Is it stress?
Or something, well, critical.
Exactly. The range is huge, benign to life-threatening.
Which is why we need a clear path.
Yeah.
So our mission today is to process this complex diagnostic guide. We found it's literally a clinical pathway to help you quickly sort the common stuff from the critical signals, based on the source material, of course. But first things first, like any emergency situation, our sources say you start with triage. Is the patient stable or unstable? That ABCDE assessment.
And that initial filter is absolutely vital. If someone's unstable, issues with airway, breathing, circulation, the headache itself kind of takes a back seat for a moment.
It's no longer just a headache problem.
No, it's a sign the whole system might be collapsing. You skip the detailed history for now. It becomes all about stabilization. So what does that look like practically?
It's immediate action. Securing the airway, maybe even intubation and ventilation, getting 5E access right away, continuous monitoring heart rate, blood pressure, oxygen, cardiac telemetry, and crucially, managing potential increased intracranial pressure or ICP.
Okay, wait. Increased intracranial pressure. That sounds serious. If someone has a terrible headache, what does that actually mean? What are we fighting there?
It means the pressure inside the skull is dangerously high. Think of the skull as a fixed box. If there's swelling, maybe from bleeding or an injury, there's nowhere for it to go.
So it squeezes the brain.
Precisely. It compresses brain tissue, cuts off blood flow. And the worst case scenario is brain herniation, where part of the brain is pushed out of place. That's why we watch the cardiac monitor so closely, looking for signs that might be happening. It's the highest alert level.
Wow. Okay. That definitely frames the severity. But thankfully, most people showing up with head or face pain are stable.
Right. That's the more common scenario.
So once we've ruled out that immediate danger, the diagnostic work really begins. We need a focused history, a physical exam, and you mentioned something often overlooked.
Yes, the fundoscopic exam, looking into the back of the eye.
Why is that so important here?
Because the optic nerve connects directly to the brain. It's essentially a window into what's happening pressure-wise inside the skull. If the pressure is high, we can often see changes in the optic nerve head. We'll definitely circle back to this when we talk red flags.
Got it. Okay, let's start this diagnostic journey, maybe focusing first on facial pain specifically. There's one type that often gets mistaken for a dental problem, right? Trigeminal neuralgia.
Ah, yes. Trigeminal neuralgia is, well, it's quite specific and frankly brutal in its presentation. It affects the trigeminal nerve, causing this recurrent one-sided facial pain.
And it's not just a background ache.
No, it's incredibly brief seconds to maybe a couple of minutes. But the pain itself is described as sharp, shooting, almost like an electric shock, really intense.
And the triggers are everyday things, making it awful to live with.
Exactly. Minor stuff, shaving, brushing your teeth, chewing, even a light breeze sometimes. Things that shouldn't hurt at all.
So how do you diagnose that?
It's largely clinical. The physical exam is usually normal, though sometimes you might find a subtle sensory loss on that side of the face. But if the fundoscopic exam is clear, no signs of pressure, and the story fits that pattern of brief electric shocks triggered by touch, that's usually enough.
Okay, that's a very distinct picture. Now let's broaden out to generalized headaches. But this is where that critical filter comes in, isn't it? Before jumping to, it's just a tension headache.
You have to rule out secondary causes, meaning the headache isn't the main problem, it's a symptom of something else going on, potentially something serious. This is where the red flags are indispensable.
And the source uses a great mnemonic for this, SNOP10.
Yes, SNOP10. It's fantastic. If any of these flags pop up, your thinking has to shift immediately from primary headache, like a migraine, to secondary headache, which needs urgent investigation.
All right, let's break SNOP10 down. The goal is to spot those warning signs. What do the letters stand for? First, S.
S is for systemic symptoms. Think fever, chills, unexplained weight loss. Suggests infection, inflammation, maybe even malignancy.
First N?
N for neoplasm. History of cancer, basically. A new headache in someone with cancer is worrying.
Second N.
N for neurologic deficits. Any new weakness, numbness, trouble speaking, double vision, anything suggesting the brain itself isn't working right beyond just the pain.
Makes sense. Then the O's. First O.
O for onset, specifically sudden or abrupt onset. The thunderclap headache we'll talk more about later. Maximum intensity right from the start. That's a huge red flag.
And the second O.
O for older age. New onset headache or a significant change in headache pattern, especially if you're over 50.
Right. Getting your first migraine at 60 is much more concerning than at 20.
Exactly. Then you have the 10 Ps. These are more specific features.
Okay, give us some key examples from the P list.
Sure. Pattern change is a big one. Your usual headaches suddenly feel different or become much worse. Positional headache pain that changes significantly when you lie down versus stand up. That could point to issues with cerebrospinal fluid pressure.
Like a lead.
Could be a leak or high pressure. Also, precipitated by coughing, sneezing, or straining things that normally increase pressure inside the head briefly. If that triggers bad pain, it's a concern.
And this links back to the eye exam.
Yes. Papilledema, that's the swelling of the optic disc we see on the fundoscopic exam. It's a direct sign of increased intracranial pressure.
Okay, so physical evidence you can see. What else from the Peelies?
Progressive headache, one that steadily worsens over days or weeks, never really letting up. And the last one we'll highlight is painkiller overuse, or medication overuse headache. While not acutely dangerous like a bleed, it's a common secondary cause that needs recognizing.
Okay, so that SNAOP10 list is our crucial safety net.
Absolutely. If none of those red flags are present, then we can feel more comfortable considering the primary headache disorders.
Right, the danger zone is hopefully cleared. And then differentiating between those primary types really comes down to a few key features, doesn't it? Like, is the pain on one side or both? What else comes with it?
Precisely. Let's start with the most common one, tension-type headache.
The classic stress headache.
Sort of, yeah. Key features. It's usually bilateral, both sides. The quality is more of a pressing or tightening, like a band around the head. Non-pulsating.
Intensity.
Mild to moderate. Importantly, it's not typically worsened by routine physical activity. Walking upstairs won't make it dramatically worse, unlike some other types.
And what about other symptoms like nausea or light sensitivity?
Usually absent. Patients might report either photophobia sensitivity to light or phonophobia sensitivity to sound, but usually not both, and typically no nausea or vomiting. That's a key differentiator from migraine.
Okay, so bilateral, pressing, not worse with activity, minimal associated symptoms. That's tension type.
Got it.
Now, what if the pain is unilateral, one-sided, and really severe?
Okay, unilateral and severe opens up other possibilities. The next question is about the patient's behavior and associated signs. If you see severe unilateral pain, often around the eye or temple, plus the person is restless or agitated.
Restless, like they can't sit still.
Exactly. They pace, they rock, they might even bang their head. Very different from someone with a migraine who wants to lie still in a dark room. If you see that restlessness or certain autonomic features on the same side as the pain, you suspect cluster headaches.
Autonomic features, what does that mean?
These are signs controlled by the autonomic nervous system, happening only on the side with the pain. Things like eye redness, tearing, a droopy eyelid, a honey or stuffy nostril, maybe facial sweating.
Wow, okay. So intense one-sided pain, plus restlessness, plus those specific local signs. That's the cluster picture. How long do they last?
Relatively brief, actually, 15 minutes to maybe 3 hours, but they come in clusters, meaning they can happen multiple times a day, every day for weeks or months, then disappear for a while. Horrific for the patient.
Definitely sounds it. Okay, so if it's unilateral, but without that restlessness or those specific autonomic signs, what's next?
Then we strongly consider migraine. Migraines typically last longer, from hours to even days.
And the key features for migraine?
You usually need at least 2 of these 4. Unilateral location, pulsating or throbbing quality, moderate to severe intensity, and crucially, it's worsened by or makes you avoid routine physical activity.
Ah, so the opposite of tension type regarding activity.
Correct. And the other defining feature is the associated symptoms. Migraines often come with nausea, sometimes vomiting, and both photophobia and phonophobia. That combination is classic migraine.
Wanting darkness, quiet, and just stillness.
Exactly. That whole sensory avoidance package is very typical.
Okay, that clarifies the big 3 primary headaches. But let's loop back to those red flags. If SNOP10 flags are present, indicating a secondary cause, the next step is usually imaging, right? A head CT.
Yes. Head CT is typically the first imaging step if you suspect a dangerous secondary cause based on red flags.
Now, what if the red flags are there, but the CT scan comes back normal? Does that mean we're in the clear?
Not necessarily. A normal CT with red flags still leaves several important, potentially serious conditions on the table. We need to consider things that might not show up well on a standard CT.
Okay, what are the main concerns in that scenario? Red flags present, but CT looks okay.
Four big ones to consider. First, giant cell arteritis, also called temporal arteritis. This almost exclusively affects people over 50.
Right, the older age red flag. What are the symptoms?
New headache, often localized to the scalp or temples. There might be tenderness when you touch the temporal artery. Visual changes are a major concern. Blurriness, double vision, even sudden blindness. And a very specific symptom, jaw claudication.
Jaw claudication.
Pain in the jaw muscles that comes on specifically with chewing and gets better with rest. They might also have a history of polymyalgia rheumatica, aches, and stiffness in the shoulders and hips.
How's that diagnosed?
High inflammatory markers in the blood, ESR and CRP. The fundoscopic exam might show issues like optic disc swelling. Definitive diagnosis usually requires a biopsy of the temporal artery showing inflammation. It's an emergency because vision loss can be permanent if treatment is delayed.
Okay, GCA. What's next on the CT normal list?
Infectious meningitis. We know the classic triad: headache, fever, neck stiffness.
But it's not always all three, right?
Correct. You might also see confusion, sensitivity to light, nausea, vomiting, maybe seizures. On exam, we look for signs of meningeal irritation, that stiff neck, difficulty flexing the chin to the chest, and those specific signs, Brzezinski's and Koenig's signs.
And diagnosis relies on?
Lumbar puncture. Analyzing the cerebrospinal fluid, the CSF, you'll typically see signs of infection like high white blood cells, high protein, and hopefully identify the bug with cultures or PCR.
Got it. Third category.
Medication overuse headache, or MOH. This is more chronic. It's when someone with a pre-existing headache disorder, like migraine or tension type, starts taking pain relief medication too often.
Like NSAIDs or triptans.
Yeah, or even simple analgesics like acetaminophen or opioids. If they're using them frequently, the criteria often mention 10 or 15 days per month depending on the drug. For at least 3 months, the medication itself can start causing headaches or making the underlying ones worse and more frequent.
A vicious cycle.
Exactly. The headache becomes chronic, often daily, and the meds stop working as well. The cure is actually withdrawing the overused medication, though that can be tough initially.
Okay. And the fourth one in the CT normal group.
Idiopathic intracranial hypertension, or IIH, also known sometimes as pseudotumor cerebri.
And this has a pretty specific patient profile, doesn't it?
It does. It's most common in biological females of reproductive age who are obese.
Symptoms.
Headache is the main one, often worse with things that increase pressure like coughing or bending over Valsalva maneuvers. They might report transient visual obscurations, like their vision briefly graying out, and sometimes double vision. And a really characteristic symptom is pulsatile tinnitus.
Pulsatile tinnitus.
Hearing a rhythmic whooshing or pulsing sound in their ears, often in time with their heartbeat. It's like they're hearing their own pulse.
What do you see on exam?
You might find visual field defects, decreased visual acuity, sometimes a sixth nerve palsy causing double vision, and crucially, on fundoscopy, papilledema, those swollen optic discs again, confirming high pressure.
So how is IIH confirmed if the CT is normal?
You'd usually get an MRI and MR venogram to rule out other causes, like a venous sinus thrombosis, which should also be normal in IIH. The definitive test is a lumbar puncture. In IIH, the CSF fluid itself is normal, but the opening pressure is high, typically measured as 25 centimeters of water or greater.
Okay, so even with a normal CT, if those red flags are there, you still have these serious possibilities: GCA, meningitis, MOH, IIH.
Correct. The investigation doesn't stop just because the initial CT is clear.
Now, let's shift to the scenario that probably feels the most immediately alarming. Red flags are present and the head CT is abnormal.
Yes, this immediately escalates things. An abnormal CT in the context of worrisome headache symptoms puts vascular catastrophes right at the top of the list.
And the classic one everyone hears about.
Subarachnoid hemorrhage, or SAH, usually from a ruptured brain aneurysm. This is the cause of that textbook worst headache of my life.
The thunderclap headache.
Exactly. Pain that reaches maximum intensity almost instantaneously, 0 to 60 in seconds.
Our source material also mentions something called a sentinel headache.
Yes, that's important. Sometimes, days or weeks before the major rupture, a small leak from the aneurysm can cause a less severe but still sudden headache. Recognizing that sentinel bleed can be critical.
What else might you find on exam for SAH?
Neck stiffness is common due to blood irritating the meninges. You might see papilledema from increased ICP, and sometimes a specific finding on fundoscopy called a subhyaloid hemorrhage, a distinct, often boat-shaped bleed near the optic disc. But the diagnosis is really confirmed by seeing blood in the subarachnoid spaces on the head CT.
Okay, SAH is a major one. What else with an abnormal CT?
Another critical vascular issue is venous sinus thrombosis, or VST. This is a blood clot forming in the large veins that drain blood from the brain,
How does that present?
often as a headache that gets progressively worse over days or weeks. It might be associated with seizures, confusion, or focal neurological deficits, depending on which sinus is blocked and the extent of brain injury.
Are there specific risk factors for VST?
Yes, quite a few. Things like recent infections and COVID-19 has emerged as a notable risk factor, but also ear or sinus infections like mastoiditis. Pregnancy and the postpartum period are high-risk times, use of oral contraceptives, head trauma, and underlying conditions that make blood clot more easily, known as thrombophilus.
How is VST diagnosed on imaging?
Sometimes the non-contrast head CT might show signs, like a dense clot in the sinus, the cord sign, or signs of venous infarcts. But it's best confirmed with dedicated imaging of the veins, either a CT venogram or an MR venogram, which will show the lack of blood flow through the clotted sinus.
Right, so abnormal CT really points towards these urgent vascular problems.
Definitely SAH and VST are key considerations when the CT shows something acutely wrong in a patient with red flag headache symptoms.
Okay, we have covered a huge amount of ground here, from that immediate ABCDE triage for unstable patients, through applying the SNOP10 red flags as that crucial safety filter,
The essential step.
then differentiating the primary headaches, tension, cluster, migraine, based on their unique patterns.
Laterality, timing, associated symptoms.
And finally, navigating the secondary causes based on whether the CT is normal thinking, GCA, meningitis, MOH, IIH, or abnormal, pointing us towards SAH or VST.
It sounds complex, but that structured approach, unstable versus stable, primary versus secondary using red flags, then CT normal versus abnormal, that pathway is really the key takeaway. It provides a logical framework to approach what can otherwise feel like an overwhelming list of possibilities.
It really does bring order to the chaos. And, connecting back to those red flags, particularly the P for progressive headache, the pain that just keeps getting worse, our source material offers one final clinical pearl, something critical to remember even when imaging is abnormal.
Oh.
That progressive pattern isn't just for things like VST, it's also classic presentation for intracranial neoplasms, brain tumors, or brain abscesses, those localized pockets of infection. So even with an abnormal scan, if the story is one of relentless worsening pain over time.
You absolutely have to keep tumor and abscess on your differential diagnosis list. That's a crucial point. That progressive nature signals something is growing or evolving inside the skull.
A really important final thought for anyone trying to make sense of these symptoms.
Excellent.